Right now, I have as my guest, Sir Paul Inyang, illustrator to the show. As anyone who watches us frequently knows, he's a psychotherapist based in Maryland, and he's of Nigerian descent. He has also been doing a lot of work as far as mental health treatment in Nigeria. And the last time he was a guest on this show, he and I were discussing the challenges of access to mental health treatment in Nigeria. Tonight he is back to continue with that conversation, and he and I also will not just be talking about those challenges, but we'll be talking about how what kind of role everyone can play, especially those of us who live outside of Nigeria and are mental healthcare professionals or healthcare professionals of any sort, and those who are also living in Nigeria, how we can all collaborate to make sure that the people who require the help actually get it. So, Sir Paul, welcome back to Let's Talk.
Thank you very much. I'm glad to be here, Dr. Hill. It's a pleasure to be back and to deal with this crucial issue of mental health as well as other things. We are due to make some strides in this area, and so here we are trying to make a difference.
Yeah, and I was just wondering if, for starters, you could just run through the various challenges that we identified the last time that we spoke. The challenge that really one could see as obstacles to efficient or as sufficient access to treatment in Nigeria for those people who have mental health issues.
Well, I think what would help is to put things into numbers because it's numbers have a way of speaking to us in a way that we can understand. Nigeria is a country of probably 150 million people, and by estimation, about 20% of Nigerians are through United Nations figures that 20% of Nigerians have mental health issues. Then we have, as a result, there is a gap between what the services we receive and what is available to us. We have a total of 8 hospitals, mental health hospitals in the country, and we have less than 12 mental health patients. About 20%, less than 20% of mental health patients actually receive treatment. 10% of those 20% utilize public mental health services, and 10% return for follow up in terms of rehabilitation services. And but to give you an idea of the the lack of infrastructure that we have, I'll just read this over to you, and that is that there are about 0.04% 0.4% of per 100,000 persons available. That is 0.4 persons are available for per 1,000 per 100,000 person is in terms of mental health professionals. 0.4% of of mental health professionals. Then we have 4 psychiatric nurses. It's estimated that we have about 4 psychiatric nurses per 100,000 persons. Then we have 0.4 psychiatrists per 100,000, 0.2 psychologists per 100,000, and 0.2 social workers per 100,000. So, I mean, you can see based on that, those figures that, we are hardly near where we need to be. And the issues we raised were that, there were some barriers to mental health services, and they fall into 4 categories. The first 3 are cognitive, affective, and orientation. These are all cultural, have cultural implications and are stigma-based barriers. Then you have actual physical barriers that exist, which would break down into financial, accessibility and availability of the services that we need. So those are basically what we dealt with. We also ventured into the fact that Nigeria does not have currently does not have an up-to-date mental health policy. The last one was done in 1991, and there was a proposal for a new one in 2003. It was withdrawn in That proposal was withdrawn in 2009 and then resubmitted again in 2013. But it has not been moved forward at all. But they covered four basic areas: one, advocacy; the other was promotion; the third item it covered was prevention; then there was treatment and rehabilitation. Those were the things that we sort of covered in a nutshell in the last discussion.
Thank you. I think I heard you say that according to figures given by the United Nations, that 20% of Nigerians are mentally ill.
Yes.
That's a very big number because it will mean one out of every five Nigerian.
Yes.
And
That's the estimated figure.
right, so how will they know that in a country where it is very hard to get figures? Whether you go qualitative or quantitative,
Okay.
it will be very difficult to have people that will come forward and say that they do have mental illness, and those people have not even been diagnosed or screened. So I'm not sure how they came
I
about a
think
figure that
I
high.
think I think this is based on representative um, uh, studies that have been done, and it is through localized communities, mostly in the southern part of Nigeria, where the studies have been done. But I think there's a representative sampling that is done, and based on those figures, there are estimates made as to what the numbers are for Nigeria. I'm not sure how accurate they are, and it's I think it is hard to say that those figures are actually accurate, but it is just I think it paints a picture in terms of the magnitude of the problem that we have within the country, and so that's those are the figures we have. The studies are being done. I'm aware that the studies are being done at this time, but we they haven't been conclusive, so we don't know for sure exactly what those studies will reflect at this point.
Right, let me tell you why, what I'm thinking.
Mhm.
As you know, when I one of my books is actually called Stress Skills, which is really my last book, or let's say the most recent. And when I was writing that book, I was very conscious of the African context, about which this book was written. Let's say it was written against that background because the things that I actually discussed, really you will find in any part of the world. But the African situation is unique. My I understand, as you and I do, that the stressors that people deal with in that part of the world are very extensive. Therefore, the degree of stress is very high. But not all stress and mental illness are not the same thing. So I'm just wondering if you look, for example, at some of the indicators of stress, some of them might also mimic some of the symptoms of mental illness.
Yes.
So I'm just wondering if we have foreign investigators or researchers that are not so versed on mental health issues, is it possible that they are mixing up these things in their studies and looking at people who are under tremendous stress and actually saying, well, they're mentally ill?
Well, that certainly could be true because Africans have a the way Africans deal with stress is quite different from the way other people in the world deal with stress. Um, I think there is a resilience about our people that we have a tendency of dealing with issues in um, in a different manner. But I'm not so sure about. I would quarrel with the figures. I think because most of what happens in Africa is underreported, and there are issues that exist within the local communities, especially the hinterlands of Africa, that never get come out to the public. For instance, if we are looking at mental health as it is, most of the mental health that is treatment that occurs in the villages among traditional practitioners, and most of the treatment is out there. And but oftentimes, what we look at is the ones that exist in the urban settings, and those are not really accounted for as such because of the mode of treatment, and there has really never been an integration of practices in Nigeria where even though we know that the local practitioners are quite important in terms of treating mental health, they've never been brought into the system or integrated into the system to establish maybe best practices, or even make them aware of some other issues that may exist. So you are quite right. It may be interpreted as differently, especially when. But most of the studies I've reviewed, most of the things I have reviewed are actually written by Nigerians, and so it's coming out of the universities and the studies, and it may be sponsored by the World Health Organization or donor agencies outside the country. But most of the reports are written by Nigerians.
And I am just wondering then what studies like that recommend as a way out.
Well, unfortunately, there is not much being those studies don't really. Most of the studies are most come under two categories. One is evaluation, the evaluations of existing structures, and assessments of how the structures are being used and to what extent it is assisting the people. In terms of taking the next step, where would be to look at advocacy, promotion, or even prevention issues. These are still things that have not been addressed, not in policy, not in practice. We still have a long way in terms of seeing what the recommendations. I know that most of the practitioners are of the opinion that there needs to be an integrated practice in Nigeria where not only do we have the Eurocentric approaches to mental health, but that it considers the local practices and assesses the local practices and tries to bring it up to par. That is a challenge. That is truly a challenge because first of all, it's the language of mental health. It does not coexist in the same realm when you are talking about what is in urban practice and what is in local practice. There's a lot of studies that need to be done, and there's a gap that needs to be filled there in terms of the information.
Right, which means to me that if you are going to make a mental health diagnosis, including all of the differential diagnostic procedure that you'll be using to come up with a diagnosis, there needs to be some understanding of and also some allowance for cultural context. Therefore, if one, for example, were to look at oppositional defiant disorder or any such thing,
Mhm.
and or even antisocial personality disorder or conduct disorder, And someone looked, for example, at what happens in Africa and looks at what happens in the rest of the world. And you see, for example, that in Africa, oppressors reign supreme. Oppression reigns supreme. And Africans just do nothing and just live as oppressed people without even very often seeing it as oppression. But in this part of the world, in the Western world, people will rise up to oppression. So, would you be using the same measures for making a diagnosis in that case? Or would you be saying um, Africans really are just lack knowledge about mental illness, whereas in this part of the world they do? Or would one be saying that in Africa there are no, that we don't have people in Africa that are conduct disordered? You know what I'm saying? I mean,
Yes, I understand.
right.
Yeah.
So there couldn't really be a universal measure for determining what mental illness is and how to diagnose it, could there?
No, there can't be. I think that one of the things that is sorely needed is the customization of those practices to the African paradigm. Now there have been there have been people who have come up with different practices, as I mentioned last time. For instance, the Afrocentric approach to dealing with mental illness, which is based on principles that are brought out of Africa. Um, there are also there is the practice itself in terms of diagnosis within the African context. There are many different things that come into play because we also the spiritual component is something that is very very important within the African context. We don't see mental illness in the same way. For instance, someone who is depressed, uh, you cannot. Although when you see depression, you would know it as a practitioner, but within that, in terms of describing depression, you wouldn't use the same parameters in terms of describing depression. So it plays within the local context. It's within the local context itself. It plays out in a different manner, and I think that the word depression doesn't really exist in within the African. That would be something you would have to explain to an African what you mean. An African is either sad, happy, or unhappy.
Right.
It is there's nothing that tells the African, okay, you have depression, but as a practitioner I can interview someone and maybe come up with that conclusion, but it's not based on what I know to be local practices. That's where the problem. That's a very big part of this, where we need to integrate the service to get an understanding of what the local practitioners think, and also see whether it is even it can be integrated to the best practice of the Western practices.
Isn't there then a big problem with that? It's such that, for example, Africans really tend to be in denial when it comes to mental illness, because there is the feeling, for example, oh no, depression is a white man's disease, or the treatment for attention deficit hyperactivity disorder is a belt or a very nice cane from the bush. Whereas, there are some things that you can see some manifestations of these things in the African society. Maybe we just don't talk a lot about them. I'll give you an example. I was in Nigeria speaking to a group of media executives, and that's right after my book came out, Stress Skills, and we were talking about stress and talking about work stress in particular. And so a lot of questions were being asked, and I spoke about depression, and I spoke about stress also in relation to suicide, and used a bunch of examples from various countries. And I said, The fact that stress is such a big thing really is something we should pay attention to, because it's something that even the UN recognizes, and the UN has called work stress, for example, an epidemic. And someone in the audience actually said to me that his friend committed suicide. Not long before I was there, the friend who actually was a pastor had committed suicide, and people didn't even think he was suffering. So the suicide just came as a shock. And a few friends knew that he was struggling with things, but just thought he would get over it. So my question then is that when our people think that these things don't exist there, and that there is no mental illness unless somebody is actually is actually without clothes and on the streets doing some negative things, uh, then there really is no mental illness. Those are the people that are mentally ill. Isn't that really either a denial or just a lack of awareness?
it, it's both. It's both denial and a lack of awareness, because the because of the culture itself. There's a cultural component with it to it. You know, the stigma that comes with mental illness. Also, the religious interpretations of mental illness and local interpretations of mental illness. For instance, you know, if you go into the hinterlands and see how people are mental health people are treated. They're treated quite differently. You have people who are chained to posts, and there is a belief that there is an evil spirit in them and it needs to be beaten out of them. And so that is one of the things that they do in terms of responding to mental illness. There is a gap in awareness. There is a big gulf that exists in awareness as to not only identification of mental illness, but also treatment of mental illness and rehabilitation, continuous rehabilitation of the mentally ill. So we need there is a need for that awareness to create an environment where there is awareness of these issues, and also relabeling of the issues as it relates to our local interpretation. For instance, you know, sometimes I encounter people who come to me and say, "Well, I just don't feel good." And I ask them, I say, "Well, why do you say you don't feel good?" I say, "I don't feel like doing anything. I don't feel, I'm sad all the time, and I sometimes break out and cry intermittently for no reason and stuff like that." And I know where my mind is going in terms of diagnosis at that point. But to them, they don't see it. They see it. They interpret it differently. They see it as some kind of spiritual thing. Some of them see it as some kind of attack on them, and so there are many different interpretations to those things. But if I were to tell them, I say, "Well, you know, it seems to me that you are depressed." They'll ask me what that was, you know, and it is hard to put it in words which they can understand it. And so, the what people will do is, instead of going into the detail of trying to explain what depression is and trying to localize the language for depression, they will immediately suggest, "Okay, well, you need to take medication, or you need to go and see so and so person who will, who will pray for you and deal with the problem." And so there's that denial, and then there is that disbelief that there is a problem in the first place. It's attributed to something external. It's always there's something external that drives the illness. So they don't look inwardly into the illness as to what may be contributing, such as experiences, traumatic life experiences, and how someone has been treated over the years and stuff like that. It is agreed that the greatest risk the population that's at greatest risk in mental illness in Nigeria are the women and the children, you know. And yet, if you look at our policy, there's nothing that addresses those two populations. There's nothing really. At the time that someone is mentally ill, they're usually walking on the street, and that's how we know that there's a crest in their illness.
You know that here in the United States, we know that even at times, there are certain times of the year when people's moods will change. And there are times when even not just the mood, but everything else that leads to that will change and impacts or influences what the rest of us see, which is one reason why, for example, we have seasonal affective disorder. So I just would like you to explain that within the Nigerian context, where, for example, this is holiday season. A lot of people go home, go to their villages back home, but there's a lot of celebration back home. How might you tell that someone, even within that festive time, may be experiencing difficulties that one could relate to mental illness? How can you discuss that against the background of the fact that Africans generally are very festive people?
Well, it is true that Africans are festive. As Christmas in Africa is a little bit different from most
A,
places.
a little?
A lot different. Let's say that it's a time for celebration. It's a time for noise. It's a time for getting together of people. But we know that based on history, I mean, research that these are also the loneliest time for a lot of people. Although there is noise, there is loneliness that comes with that period. Some people do not have anybody. They may be in families, but they are socially isolated, and they are emotionally isolated, and there is certain loneliness that comes with it, especially for one or many different reasons. But it is not acknowledged because it's a communal thing. And there are people who would say, come on out, and join us and celebrate." But at the end of the day, one has to go back home and deal with their own personal issues, whether it is loss and grief issues that come up. We tend to come up this time during this time of the year. I'll share my own personal example. If I'm in Nigeria for the Christmas, the first thing that comes to mind is that when I walk into the house, mom and dad are not there, and I'm used to having them there, for such festive occasions. So it brings up certain emotions in me, and it brings up certain feelings in me. I have to be self-aware enough to understand that although this is a festive occasion, I'm going to have some difficult times with this. But there isn't that sensitization to let people know that these things exist. So you have people surprised when you hear someone say, "Okay, well, they committed suicide." Suicide, within the Nigerian context, is abomination. You are going straight to hell. You are going straight to hell, if you commit suicide. Such a person is really, in some circles, there's no mercy for such a person. Well, how dare you? How would you even dare to take your life? But they don't understand the circumstances are surrounding the illness, or what prompts someone to feel so lonely within such a noisy environment to be able to think about killing themselves or getting out of their lives. So again, it goes back down to some depression, and like you said, seasonal affective disorder and stuff like that exists, and that it's not identified and treated. Counseling within the African context is very different. There is the church counseling, there is the individual counseling that one gets from their family, and there is the community uh, community counseling that exists sometimes, but none of it addresses really the core issues of mental illness. It's within the cultural norms and values of the people, and so they keep it that way. Another good example would be I counted a couple who was having difficulties, and the difficulties were so bad that they were aware of the fact that it may be better for them to separate. But within the culture, it is within the culture that they came from, that was an abomination. So rather than separate or leave, they accommodated each other through that process. And I mean, all you had to do was talk to them, and you would know that both of them were so depressed that they were going out of their minds because of the expectations of societal expectations. So these are the things that exist within during these celebrations that we don't know, and it is not defined, and there's no way to treat it. So it's a problem. It is a problem. This time of the year, it's a real difficult time for most people. Um,
And we are, of course, talking about a society where we don't do enough publicity around public health issues. And mental health should really be a public health issue. And we don't really do a lot of work going out and not just advocating but educating unless there's a disease. Then public health officials are out there talking. So, what I would like you to do is also consider the fact that we both know that in many fields of work in Nigeria, Nigerian professionals are very committed to what they do. They are very dedicated and do very good work because they are generally hardworking people. So we identified the last time that we spoke that the Nigerian professionals in the field of mental health may not just be as equipped with the resources that they need to do the work that they are doing. How do you think that Nigerians who live in other parts of the world where the resources are available can be of help to make life easier for those mental health professionals who are working in Nigeria?
I think what the biggest thing that needs to happen is educational transfer. You know. There needs to be that transfer of knowledge. There needs to be some coordinated way of transferring knowledge to people who are at home who are dealing with these issues. Because as I mentioned earlier, we don't have enough of the training that exists. There are approximately about 12 medical schools in Nigeria, probably more now with the new configuration of universities, and all of them have they treat mental health on some capacity uh, within those uh, within those medical schools, and they train people, but we don't have enough people. So there needs to be a commitment to go back and give services. Even if it may require some pro bono services in training and in actual practice, in the practice. For instance, we were talking about how you come up with the data that I just spewed out here. There are many creative ways of getting data that we need to transfer to even a common assessment that you do is gives you not only subjective data, it gives you quantitative data. So I mean, how to transfer the knowledge of collecting the data and collating the data, and then being able to interpret the data enough to make a case for the issues that exist. Because I think one of the things we struggle in Nigeria is being able to make a case for mental illness, because there is such a big like you mentioned before, there's denial, and then there's the lack of awareness. To make that case, sometimes we have to be able to create some kind of data that can really make sense to the people. Both subjective and quantitative data. The other thing that we need to do is that there's the finances. Financial issues are a real serious barrier that we have, and those who can attract funding from sources to go and do work at home, that would be very, very helpful. That would be so helpful because there's a lack of resources for even not only the practice but research and so on. Then there is the practical assistant, which is bringing the best practices back home. That's the professionals can do that. That would be something we can do. We can do very easily. But most, I don't know that we look out. We look back to Nigeria as much as to look. We need to be able to help build the society. And this is our niche. This is what we do. This is what we know. We know how important it is. We see that. We see it every day. And in terms of, for instance, medication, stuff like that, we have psychiatrists. Some of the best psychiatrists are Nigerians. And I've encountered them in my practices. And bringing back those medications and teaching people have patients, helping them find resources to acquire those medications, are things that can be helped. But also the need to help create an awareness for the issues. That doesn't require money as much. You need help in terms of being able to promote. I think that we can help in terms of creating other problems. And there's an area we haven't even touched, which is not only the correlated issues, such as one that come up, have mental health associations with them. So there is so much that we can do as so-called practitioners in the course.
There's also, I'm thinking, I'm not sure how many people who go to medical school in Nigeria go on to become psychiatrists. And I don't think that's just a Nigerian issue. I know that in Ghana a few years ago, when I was speaking to healthcare professionals, some of the psychiatrists told me that in Ghana, there was one psychiatrist to 2 million people in Ghana, which is really a huge thing. And I am not sure what the ratio is in Nigeria, but I'm wondering if perhaps it might help if someone began to talk about giving incentives to prospective medical students who would want to specialize in psychiatry.
It is true, but let me ask you a question, Dr. Ohiro. Can you imagine in school telling your parent that you want to go work in psychiatry?
Yeah.
The question would be, what are you in psychiatry? Then you explain that he's working with you for crazy people, and then they say, "Are you? Have you lost?" You would be immediately discouraged. There are some psychiatrists. I think the medical comes to going back and giving back to those teaching within the medical schools. Unfortunately, we recently lost a top-notch psychiatrist here in Delaware. That lost her life. And that during the service services. Several Nigerians who went to school at Uniben, um, University of Ibadan. There were some that came out of University of Lagos, and they for this other stuff. There was a house full of psychiatrists, and they were as if I were counting at least about 2 psychiatrists within that environment, And those people like that can go back and help the training of psychiatrists, and letting people understand the importance of this practice, and being able to help out. It's awareness we are talking about, and letting people see the opportunity that just like you would make the case in psychology, and let them understand the differences between the two, and like that, and so again, it's going back to what my original, in which creating an awareness, understand the import of the issue point, that to the government to put resources, and also attracting resources from outside to it.
Yeah, all of that is very important. And I think that at some point, discussions also need to be had. Our general level of a system of in Nigeria.
Yes.
Emphasis still going to be on the big professions. Everybody wants to be a lawyer or something, and a big accountant, a big doctor. But there are others that are very important of psychiatry for the treatment of psychiatric illness, and so it does require a lot of reorientation in our society to be able to do that. So, go ahead.
I think professionally, Nigeria has always been theoretically oriented in terms of things. I think we are beginning to evolve a little bit to the practical aspects of life. But I remember that if you asked, when I came out of college, if you asked me any theory you wanted to in chemistry, I could tell you this theory. But if you asked me how to put it to practice, that would be my problem.
Yeah.
Okay. I took years of learning here, learn the theory of psychology, to then begin to the practice of psychology. There are two different things. What you learn in theory isn't helpful unless you can make it happen in practice.
Right. It is very interesting because there a point they should actually be encouraging the study of philosophy because it has significant epistemological value when it addresses what it's intended. Right. How do you know what you know? How do you acquire knowledge? How do I know that you are the person I'm talking to? So how do I know that this person is actually well and not mentally ill? How do I know that the pastor who is telling me that God is telling him to tell me that somebody is trying to kill me is actually hallucinating? How do you know what you know? Those are things that really have very strong or even at all presence in the Nigerian educational system. My friends tell me that this is an African problem because there is no emphasis on humanities. So the emphasis on liberal arts, the emphasis is on these are things which really haven't taught to the fullest. So you have people who are graduating from universities who really haven't really done much of the practical stuff. But even if they did, well, where do they practice it?
Well, being able to distinguish between the difference between auditory and visual hallucinations. Someone is telling you they see things and all that stuff, and then being able to understand it for what it is, and to be able to differentiate it from somebody who is actually has a gift of hearing things, of a gift of hearing the voice of God, as they would say. So it is very that is where there is the trick is, because Nigerians are very God-fearing people. We believe in God. If there is a people that I know that believes in God, is Nigerians. Now, whether we can logically what we are hearing is a different matter, because that is where it is. Whether you can assess the content of what you're hearing is an issue for Nigerians, because because of their belief is so firm that it borders on denial, complete denial of what exists. For instance, I give you an example. A friend of mine actually lost his wife from ectopic pregnancy. Now, you can imagine what ectopic pregnancy is. You take the woman to the gynecologist, and the gynecologist says, "Well, this woman has ectopic pregnancy. What do we need to do? We need to do surgery." Okay. Now he goes there, and then he's told that his wife needs surgery. Then the pastor calls and says, "Well, no, that's the voice of God tells him that this will be resolved. Come back, let us pray over it." Well, somewhere in between going back to pray for it, the woman loses her life. Okay. Now you can understand what I'm saying. Now, when the man has total belief in God, he has total belief in God. He believes that God can save him. But you don't understand that surgery is also God's gift. And that it's nothing about him. Just understanding, if he takes wife to the doctor and has a pregnancy move. But what he will tell you, even in death, is that it was God's will. So, and you try to sort of debunk that within the Nigerian context, as you would say you are talking to a client and they'll immediately believe that yeah, of God. So that is a barrier in itself. You have to get over that to even get where you can tell you tell the person that they have a problem. This is their problem. You have to overcome that hurdle. So these are the issues. Some of the issues on our society, and again, it comes back to us. What we can do to help people understand these issues better and make better decisions. Again, I think as much as these other things are important, it comes down to me that there needs to be a greater awareness. There has to be a campaign for awareness on this issue. Then there are other things, the practical things we have talked about, like practitioners helping out at home in terms of the knowledge transfer and stuff like that, and being able to create the local context to describe. For instance, you wouldn't DSM-4 would mean nothing to a Nigerian. DSM-4 or DSM-5 would mean nothing to a Nigerian. Not to the practitioner now. The practitioner understands well what it is, and some of them can teach the show about the DSM-5. But the local people to affect, whose lives you are going to affect, do not understand it. And the context is really out of context for them. So you have to again go back to making it local, using local language and helping them understand within the culture what that means.
Right.
that is the struggle that we have. Yeah.
Right. So the struggle will have to continue, and
Exactly.
will have to continue. And the practical aspects of conversations like this will have to really be engaged in full force, actually, because the problem people are going to continue to develop these problems, and the people who have these problems are going to continue to help. The challenge then becomes, it seems to me, what to do. And is it possible for professionals to collaborate with professionals back home and who share that process? And how will it work in so peacefully that the goal of helping the people is actually achieved? So I like you to sum that up in your response as your final comments, actually.
This is, I believe there is an opportunity now to begin to formulate a, a plan with which we can begin to bridge the gap between us and our brothers and sisters who are practicing at home. And first of all, we need to get rid of the distrust that exists between us in terms of what our intentions are, because we really have the same intention, which is to make our people better and to help our people. And that we need to begin that discussion where we begin to look at the issue as it is and see where we can collaborate and where we can help each other overcome the overcome the issues. One of the challenges for me is for instance, how do we help each other understand, put this in numbers and interpret it in numbers. I can pretty much know the interpretation of the numbers, but how do you collect data locally and get pertinent data locally, you know, on issues like this. For instance, if we are just going back into someone's background and trying to see how far back mental illness has been within their within their family and stuff like that. But I think that there is an opportunity that we have here to begin to do practical things that will help raise this issue. And I think it starts with the discussion. One thing I would like to encourage the people who listen to this program and who have heard us speak on this program is to send in suggestions to us as to how we can help. Because really, you don't know how much you do not know until you get down on the ground and try to deal with this issue. That is within the local context, and we need them to be part of this and teach us what we don't know, because that's what needs to happen here for us to be able to bring our expertise to bear. So I'm encouraging that people should send us suggestions as to where we can go with this and how we can collaborate. I think that this coming year is a pivotal year. That would be Buhari's second term in office. I mean, second year in office, right? I would like to know what is being done in the mental health field, whether we can do something in policy to address the issue, and that will translate to practice later in terms of mental health illness. But I suspect that if we sit here and wait for that issue to be brought up, it won't happen. That we need to go and raise that issue. And that is my commitment in the coming year, to go out there and make sure that we talk about these issues and see how we can play a role within the society on mitigating some of these issues.
So, thank you very much. And very soon we will be hanging out again and having a discussion either on this or on something else. But in the meantime, I just want to wish you a very Merry Christmas and a very Happy New Year in advance.
Thank you, Dr. Hero, and Merry Christmas and Happy New Year to your folks. We need to get together and
Yes.
So
So,
I'm looking forward to a new year of possibilities.
indeed, indeed, indeed.